Welcome, my friends, to Dr. Frank, Cutting Edge Medicine. I'm your host, Dr. Frank Miller, coming to you from San Antonio, Texas. This broadcast is brought to you by O3 Plus, our health, wellness, and longevity clinic here in San Antonio. The phone number is 210-558-7778. We do a lot of things in the clinic to try to keep you healthy, and just a reminder that a lot of the things that we do in the clinic are not FDA approved. So they're not designed to diagnose, treat, cure, or prevent any disease. But we still think that a lot of the things, and we know we have a lot of evidence of a lot of the things that we do, including ozone, chelation, post-electromagnetic field, IV vitamins, and a lot of those things can augment what your physician or healthcare practitioner is doing to try to get you healthy. So let's start with a prayer. God our Father, thank you for putting researchers in our lives who can help us to figure out how to stay healthy. And we ask you to continue to bless them and to open our minds so that we can absorb the knowledge that they give us, especially today, to try to learn how to get rid of some of the pollutants that may have entered our body that are getting in the way of our health. We thank you for hearing us, and we ask all this in the holy name of God. Amen. So today, folks, we have a very distinguished guest. This is Dr. Gervasio Lamas, who goes by Dr. Tony Lamas this is from Miami, Florida. Dr. Tony, say hello.
Hi, everyone.
All right, so I understand, let's see, you're a CV, you're a chairman of medicine there and chief of Columbia University Division of Cardiology at Mount Sinai Medical Center in Miami. Is that all correct?
That's correct.
All right, and so I was looking at your history. So your parents, your father and your uncle were physicians, and your mom was a biochemist. So you came from a very scientific family. So
and my sister is a physician, and my daughter is a physician.
Excellent, excellent. So you're continuing the path. You know, my grandfather was a physician, my father a physician. I got several siblings the same way. So we talk about everything at the dinner table. So.
Right.
But I met you in 2015 at the American College of Advancement of Medicine, the ACAM meeting in November 2015, and you were giving an amazing talk on the TACT trial, the trial to assess chelation therapy. And as I recall, this trial was funded by the National Institute of Health and was designed to see if chelation could actually help with health in any way, and I think you were looking specifically at cardiovascular disease. Is that correct?
Sure, and I can expand a little bit on that, Frank, in the sense that I'm very much a conventional cardiologist, conventionally trained. I spent, I did all my training, 6 years of training at postgraduate medical training at Harvard, at the Brigham and Women's Hospital, and stayed on in the faculty of Harvard Medical School for another 9 years, and then relocated to Miami because my family was down here and so on. Okay. And so I've been hearing about chelation for many years, and I knew that it was quackery. Right? I knew it didn't work because that's what they taught doctors like me in conventional medicine.
Let's tell the audience what chelation is. You want to do it?
So chelation is using a medicine, really, which is called a chelating agent. It's just a term for that particular kind of medicine. So it's a medicine that has the ability to bind, to stick to impurities in the blood and in the body, in particular metal impurities. So all of us are loaded with different kinds of metals. If you were alive anywhere between 1940 and 1980, you were exposed to an enormous amount of lead through leaded gasoline. Same thing with leaded paint. So now they've taken out a lot of the lead paint, but of course a lot of that lands in the soil and you get contaminated that way. Tires, highways contaminate you. When you are driving your car and the battery runs out, those batteries are heavy because they're made of lead. So they take them out and take them somewhere, I don't know where, and they give you a new one, and you continue that whole lead contamination. So all of us are full of that stuff. The other one that's very toxic to blood vessels is cadmium. You say, well, what the heck is cadmium? Well, just think of those old rechargeable batteries, the nickel-cadmium batteries.
Oh.
Okay? So that's just one use. They're also used during the manufacture of plastics as a plastic stabilizer. They're used in some paints. If you talk to tattoo artists, they'll tell you that there's a particular yellow they used to use called cadmium yellow.
Wow.
So it's actually used in construction to stabilize steel, steel beams in skyscrapers. So there's a lot of cadmium around, and we all have cadmium inside us. So all of these poison the inside of blood vessels. They probably poison our nervous system, and they poison our kidneys. So it seems logical that you would want to get poison out of the body, but we were never taught that when I was in medical school. And so a patient walked into my office and he said he wanted chelation, and I said, no, that stuff is dangerous. It is doesn't work for anything, and it may hurt you. And you need to take A, B, and C. And then I got to thinking and realized that I really had not looked into the literature, the scientific literature, and I did. And I found that the scientific literature had a lot of kind of single anecdotes of success, a few poorly done studies that said that it didn't work, the chelation didn't work, and there was a giant gap in knowledge. So at that point, I went to the National Institutes of Health, and it turned out that at just that time, they were looking to do a chelation trial. And the reason is that there had been pressure from Congress because people were getting chelation. And the congressmen were saying, why aren't we studying this? Why don't you have a portfolio of this? So it was kind of a convergence. I lucked out, got this grant, enrolled 1,708 people over a course of 10 years into a study. These were all patients who had had a prior heart attack, into a study of chelation or placebo. The chelation is given intravenously, and it was 40 infusions. So let me tell you, anybody who completed it, and those 65% of the patients completed it, these are saints. You talk about heroes, these are heroes.
Because doesn't it take about 3 hours for the chelation?
Yeah, and it takes 3 hours. So, I mean, there's a lot of, there's a certain amount of burden here, and it's huge.
And we were using disodium EDTA.
Disodium EDTA is what we use.
Which is ethylene diamine tetracetic
Ethylene diamine tetracetic acid. And it's the sodium salt of it. And the infusions also had vitamin C, some B vitamins, a little blood thinner called heparin, and some electrolytes like magnesium and potassium. So we start this study. We gave 55,222 infusions. And I was sure it was going to be negative because I'd been taught that chelation didn't work. But when we stopped the study, because I remember these are blinded studies. I don't know what you're getting. You don't know what you're getting. We had 134 clinics in the U.S. and Canada infusing for us. And at the end of the study, we have like a little ceremony where we break the code. And sure enough, the darn thing works. It reduced cardiovascular events. What's a cardiovascular event? It's death, another heart attack, a stroke, hospitalization for cardiac reasons, or having to have cardiac surgery like a bypass, or having a stent placed. So I almost fell out of my chair because that is not what I was expecting.
Yeah, it's kind of like, then, now what do we do?
Yeah, because, what happens is if you run a clean study, right, what comes out at the end is what the truth is. And that's the way it is. And, and you do research not to support your bias. You do it to learn something. And sometimes it turns out your bias is right. But what I have found is that about half of the time, when I do a study and I have a strong opinion, I'm wrong. So that's why medical research is so critical, so important. So at that point, I presented at the American Heart Association, and they treated me like I was some sort, like a skunk had gotten to know me intimately first, because the cardiologist really demanded that the study be negative. Mm-hmm. And in fact, it wasn't, and we presented the truth. So, fast forward a couple of years, by then the National Institutes of Health scientists, the government scientists, which had been as biased against chelation as I had been in the beginning, but they're really, they had no axe to grind. They looked at the data and they said, this darn thing works. So I went to the FDA. The FDA looked at the data. They said, hey, this stuff works, but this is only one experiment. You got to do it again. So the first study took me 10 years. I almost fell off my chair at that point. Right. To do another large multi-year study. By 2016, we got $36 million, and we're doing it again. Wow. So right now, we have 1,000 patients enrolled. We've given about 30,000 infusions. The last infusion will be given at the end of this year, and the last patient will be followed for a year. So in a couple of years, I think that we will have a good idea as to whether or not this treatment, because then it'll be in 2 studies, becomes part of conventional cardiology. And in fact, we've also, because in between studies, you get bored, so you want to do some other experiments. Right. And I had heard from chelation practitioners like yourself that chelation really worked well for people who had arterial damage in their legs, really gangrene. And I was able to get money from our hospital, which, by the way, is the only hospital that has chelation therapy on its formulary. Wow. The only hospital, I think, in the world. And I was able to recruit 10 people who really had nowhere to go. Severe pain in their legs. Some of them had, the skin had broken down, and others had, a few of them had real gangrene going. Okay. And had been scheduled for amputations. These were all diabetics. And we started that experiment, and everybody who received at least 20 infusions got better. Boom, got better. Healed up, pain gone, and I still see some of them now. And by all rights, they should be amputees or dead. Wow, that's incredible. So now, mind you, I've published this, but is anybody reading, listening? Are any of my colleagues reading or listening? No, they're not. That's why you're on the radio today. People are interested in catheters, balloons, this and that. And this is a medical therapy that is actually extraordinarily safe. I remember after the TACT-1 came out, and I was talking over the data with one of the cardiologists at the hospital, and he says, yeah, but that won't work. And I said, well, the study says it does work. He says, yeah, but nobody does it. I said, well, we do it. And he says, yeah, but he meant to say no real doctors do it, But it's really, Frank, it's arrogance, really, that keeps you from, because you really are taught to be scientific when you're in medical school. You're taught to look at data and to be dispassionate, to be critical. If you didn't do it right, or somebody didn't do it right, it's within your rights to point it out and say, hey, this is interesting, but Well, now, and you forgot to do this. It's not valid. When you publish, when you do a clean study, the team that I put together was extraordinary. I had the best biostatistical team. Those are the people who managed the data. and do all the calculations. The best in the country. I had Harvard involved. It wasn't just me. It was probably a couple of hundred people working on the trial, and then another maybe 300, 400 people working on getting patients in.
Wow.
Along with the 1,700 patients who really, I have them to thank. So, progress is much slower. Even when you have strong data, it is much slower than you think. But it's moving.
That's good.
It is moving. There's no need to give up hope. There are more and more people like yourself who are using chelation. I hope that our study is positive, because at the end of it all, it really just makes sense that having poison in your body is poisonous. It seems dumb, but that's the way it is.
So, after the first study was released, I remember reading an article in one of the heart journals, and they were trying to pick apart your study, but I didn't really see the rationale behind a lot of it. I guess none of it really held a lot of water. Is that right?
Well, there were issues with the study in the sense that we had a lot of patients, that we had more patients than usual in studies who decided that they, were done with it, didn't want to participate anymore. The point is, though, that there are statistical techniques that you use to make up with that. And if you have a patient getting real chelation and he says he doesn't want to be in the study, that's fine. If you have somebody who's doing placebo, so they're getting just salt water, and they don't want to do the study, once they tell you they don't want to do the study, if they have a heart attack later, you can't attribute that heart attack because you're not following the patients anymore. So we had more placebo patients give up on the study. So there were more bad things happening to placebo patients that we couldn't count.
Okay.
So in fact, the study is far more positive than it seems. And that's, that is just plain as day. It's just that people were so biased that they would pick at other things and not realize that they were missing the biggest clue of all.
Right. So, what can you give us some statistics from the trial? I mean, I think, as I recall, it worked the best in the diabetics. Is that correct?
Yeah. Yeah. So the effect size, how good it was best in patients who had diabetes. In diabetic patients who had a heart attack, it reduced the risk of death by 43% over 5 years.
Wow.
It reduced the risk of either death or recurrent heart attack or stroke or having an angioplasty or coronary bypass or being hospitalized with chest pains by 41% over 5 years. It reduced the risk of another heart attack by 50% over 5 years.
Wow.
There's nothing like this. Nothing. Zero.
Well, by comparison, how does a statin compare to that?
A statin reduces things by about 15%, maybe 20% in a high-risk population.
And beta blockers, kind of the same?
Yeah, really about the same. And the way that we use beta blockers is much less, because the beta blocker studies were done a long time ago, and patients were what we call beta blocked, which means that they were receiving large doses. Nowadays, we give people 25 milligrams of Lopressor or metoprolol once or twice a day. That wouldn't have counted in those studies. Those studies, they were getting 100 milligrams twice a day.
Wow. Okay.
So, and how many people do you have walking around on 200 of metoprolol? It's like no one.
Right.
So, I'm not sure that the doses we're using now are actually doing anything, if you want to know the truth. And baby aspirin has a mild effect. So this is really, for me has been extraordinary. It's been a journey of actually discovering that that when you have a bias, you may as well test it rather than believe it. And that there are very few people who believe science over believing their bias. It's really, it's upsetting in that way and disappointing. But, you know, you do the best for your patient, and as long as there are other scientists that will support you, especially scientists who have the appropriate funding to support you, because research is expensive, then you move forward.
Yeah. They say it takes a generation to change the standard of care, and so I guess we just have to have a few more doctors pass on or something. I don't know. But the problem is I don't think they're really teaching it in the medical schools, are they?
No, they're not. They're not. In fact, somebody told me that they had chelation was in their internal medicine boards, but it was one of the wrong answers.
Wow. That's
I love that.
The revascularization piece is tremendous. You know, here in San Antonio, we have a lot of diabetics in the Hispanic population, especially. There's just a really predominance of it. Plus, part of it's probably genetic. Part of it is what we eat, and it's just so sad when. I mean, I got a vascular clinic down the street, and I really wanted to try to link up with them, but some of the impediments to chelation is cost, I think.
Well, yeah, for the most part, you can't get insurance to pay for it. Although sometimes I am able to, and what I've done is that, you know, I check urine metals post infusion. I send them a lot of my published work. And they'll say yes. So I have a few patients that miraculously have said yes. Medicare never will pay for it, and you actually will get in severe trouble if you try to bill them for it.
Wow. That's a shame. Well, so after the second study, then that's my hope actually, is that maybe the insurance companies and Medicare will realize that it's a valid tool. Is that kind of what you're hoping?
Yeah. I mean, I spoke with Medicare, showed them all the data, and they said, we need FDA approval for this. And, you know, fine. They want to play it very straight, and I want to play it straight also.
And so to get Medicare approval, what do you need besides two conclusive studies?
Well, I need the FDA to look it over and decide that, yeah, these are good studies and it counts.
Okay. What about the newer diabetic drugs like the SGLT2 inhibitors? They look like they were kind of moving closer to this, but I don't think they were in the 40% improvement range.
No, they're not in the 40% range, but they are good drugs.
Okay.
They really are. But you know, I mean, if we look at our population, we have about 10 to 15% of patients on it. And that's because of cost.
Right.
Insurance companies make it very difficult to get on these drugs.
Okay. Well, the regular insurance companies, I think, cover it, but Medicare, it's a lot harder to get it covered, is what we've seen.
Yeah, and you know, and they're life-saving. They really are. These are life-saving therapies for patients with diabetes.
Wow. Well, so to the audience, if you just joined us, we're talking to Dr. Tony Lamas from the Mount Sinai Medical Center in Florida, who knows a lot, probably the most, well, I don't know if he knows the most about chelation, but he certainly knows the most about running a chelation study in the U.S.
Yeah.
And these are the...
I know the most and the least because I'm the only guy doing it.
Well, I really commend you. I remember the story was when they said, well, you got to do another study. The rumor through ACAM was that you said, well, wait a minute, I'm sorry, I want to be with my grandchildren. You know, I just spent 10 years of my life and give me a break. But I'm really glad you kind of thought it through because nobody knows it like you do, and especially you know enough people to be able to get the funding to do the study.
Yeah, a lot of it is that it has to be the right person who gets obsessed. And you know, you can get obsessed on a lot of stuff, but if you don't know the right people, and you're not in that world. That's the thing. You got to be in that world.
Right.
And that's a world where it's, before this, these chelation studies, I had done, 3 or 4 other large NIH studies, on cardiac pacing, on different kinds of angioplasties and stents. Sort of straight arrow cardiology studies. Mm-hmm. So it's the kind of thing where they need to trust that you know what you're doing.
Right.
And as part of those studies, you always get to know people.
So, just for the audience again, this is the Dr. Frank Cutting Edge Medicine Show, and I'm Dr. Frank Miller, and we have a clinic here in San Antonio that does do chelation. It's called O3 Plus. The number is 210-558-7778. So if you are having, if you are diabetic and you've had a previous heart attack, and you're doing everything that your conventional doctor is telling you to do, and you want to have additional benefit, here's what would happen. You would come into our clinic. Our nurse practitioner, Kim Engelman, will evaluate you. You will have to sign a consent form that says this isn't FDA approved, and you will tell you how much it costs, how many sessions it would be, and then and then if you agree, then we can do it. So, it takes the official one was 40 chelations was it in a year?
It was 40, yeah. Well, in about a year. And the original study we had, the last 10 were sort of maintenance, so you could stretch it out over a year and 3 or 4 months. But in TAC 2, we're trying to keep it within a year. But it's tough. It's tough for people. Sometimes people will take a 2 or 3 month break. Mm-hmm.
What about using calcium EDTA instead of sodium? Because I've heard that you can go faster with that one.
Yeah, so I suspect that it is exactly the same.
Okay.
But the fact is that it's not what I studied.
Right.
So I can't, just being very straight arrow, mm-hmm. I can't tell you that it's the same. But in terms of removing lead and cadmium, it really should be the same. The calcium doesn't matter if it's calcium or disodium. And it doesn't really remove a whole lot of calcium, so it's not that it's decalcifying arteries. I think it's really just taking out poison.
So at one point in my chelation education, I guess, they were saying that some of it might have been due to taking out the iron, because the iron can lead to a hydroxyl radical that could maybe inflame the arteries. Is that part of it?
There's still a question. Iron exists in 2 states, +2 and +3.
Okay.
+2 iron is what your blood carries around in it. +3 iron kind of runs around free, and it's sort of like having a leprechaun loose in your body, causing mischief. And we do have a project ongoing with hopes of being able to determine if we can reduce +3 iron with EDTA. Odds are that you can. I don't know that to be a fact. Okay.
So now we had the TAC 2 trial, and that one was more specific with the
diabetes, because of the effect size is so great. We can do it with 1,000 patients. We don't need 1,700 patients.
Okay.
And then we're also doing TAC 3A, which is a pilot study of critical limb ischemia. So people with real, threatened amputations.
So if people wanted to get in your study, what could they do?
Well, we've stopped enrolling in TAC 2.
Okay.
And the other one is just too small. They need to move to Miami Beach.
All right. So otherwise, I guess they just find it. Part of it, we're still all kind of waiting.
You need to find a reliable chelation practitioner,
Mm-hmm. What do you think about the chelation products that are out there that are like you spray them in the mouth and they're supposed to remove metals that way?
Don't know. I can't tell you that they don't work. I don't think they do.
Okay.
What I would say is that all of us do these assays, these tests of lead and other metals in the urine. So if you think that your method works, check how much lead in the urine you have, and then spray yourself or do whatever else. Take a suppository or take an oral pill, then check it again. And if it's the same amount of metal, then it didn't do anything.
Okay. And so y'all are checking the metals in the urine. Some people check them in the hair and different things.
Yeah, I really haven't gone into the hair thing because it was actually hard to get. Remember, I'm running a trial in 100 sites.
Right.
It's hard to get people to do everything uniformly. And I'm working with really superb scientists in the Columbia University School of Public Health.
Okay.
And they're managing my all my biosamples.
Okay. So, like when you're checking it in the urine, is it a provocative test where you give them an oral chelator and?
Well, we don't do that. We do that in our study, but we remember it's a blinded study. I don't know what comes out.
Okay.
I can tell you I've done this, and I know that 3,000% increase in lead in your urine.
After
and
the
a
IV?
700 after 3 grams, and a 700% increase in cadmium.
Wow.
So I know these metals are being removed.
Does mercury come out also?
Not with the DTA.
Okay.
For that one, you need some DMSA.
Okay. And so you also had a recent publication, I think it was May the 4th. I guess it sounds like this was kind of still to try to keep ringing the bell that lead and cadmium are risk factors. Is that basically, that was in the Journal of American Heart Association?
Yes, that's correct. And that one, it really was to say, ring the bell is exactly correct. I think where we are with lead and cadmium and cardiologists insofar as recognizing that it is a cardiovascular risk factor is where we were in the 50s and 60s with hypertension and high cholesterol.
Wow.
It's people suspect that it's important. They don't really understand how to treat it, and they're not convinced that it really is important. There used to be, remember, it used to be that your blood pressure was supposed to rise with age.
Right.
Well, nonsense. Your risk of stroke rises with age because your blood pressure is high. It's not destiny. So we just need to get the word out. The information, the data, the scientific data that these are serious vascular poisons, it's out there for anyone to read.
So when a person has lead, it's stored in their bone, isn't that right?
It's stored in the bone, but there is also some of it is stored in red blood cells, some of it is free in plasma, and I suspect, and I don't have good proof for it, but I suspect that some of it is in the walls of blood vessels.
Okay.
As well.
Can you draw a blood test and find out if you have lead?
You can, and it will usually be very low. It'll be like 2, which, according to the recommendations, that level of 2 is fine. And most people most older people will have detectable lead. It'll be a 1 or 2 micrograms per deciliter. However, that doesn't say how much lead you have in your body. You have a ton in bone and a ton in other places.
Okay.
And so that's why doing a provocative test is helpful, because it allows you to mobilize some of that, and you can see it's like, lo and behold, it's like removing, looking behind the curtain and saying, wow, this is a problem.
So with the test that we do, you kind of get a bar graph, and it just shows you whether you're in the green, the yellow, or the red. Is that kind of where y'all's is as well?
Yeah, except that this green, yellow, red is arbitrary and I believe not accurate.
Okay.
If you look at blood lead levels, I don't know, years ago? No, maybe less than that.
Uh-oh, I lost you. Are you still there? Dr. Tony, I can't.
Yeah.
There you are. I couldn't hear you for a moment.
Yeah.
Okay.
Yeah. Sorry. So what is recognized as a normal blood lead level has been going down over the decades because it is not normal to have lead in your blood.
Right. I read there was no safe level of lead in the body.
There's no safe level. There's also no one who doesn't have lead. Maybe kids. Maybe the occasional kid.
Certainly
the longer you live, the more lead you accumulate.
That's what always worried me about those kids in Flint, Michigan, when they had that lead contamination in the water supply.
Yeah, nobody's chelating them.
I know. I think that's almost a crime, But I don't know how to get that word out. I mean,
we did. We tried to get that word out, and we couldn't get anything done.
Because even if they had, what do you think about? I guess we don't have studies to say about oral chelation with like the provocative agents that you use.
Right, exactly. Yeah, we really don't know if it would have the same effect.
Okay.
It is more likely than not.
Mm-hmm.
But, you get fooled with these more likely than not ideas.
Right. So we have to kind of stay with the studies to really know. Yeah. Okay. All right. So let's see. People ask me sometimes, with like they do a coronary calcium score, and would that be changed with chelation? What's your thought on that?
I don't think that it'll be changed. That calcium is within the wall of the artery. I don't think it's accessible to chelation. So, for example, it's the same thing with a statin. If I give you a statin, lower your cholesterol to way low, the coronary calcium doesn't really change. And the calcium is not really pathologic. It doesn't cause disease. It's just a sign that you do have disease.
Okay. So what do you think's happening? I mean, when you get the metals out, how does
your arteries become healthier?
Okay, so
they become healthier. They're less damaged. They're less likely to let in fats. They're less likely to promote clotting. They just are healthier.
So it's not that we're pulling out calcium, and so there's no real point to, even like if you had a carotid intima media thickness, a CIMT of your neck.
I don't know. A CIMT is a little bit different. That's not calcium dependent.
Oh, that's right.
I know that statins do reduce that, so it's conceivable that chelation might do that.
Okay.
We never tested it because it's very expensive and a very finicky test.
Okay. What was that?
Do you think if they had an ultrasound of the carotid, will that decrease the amount of occlusion with the chelation therapy?
I have a couple of patients where that seems to have happened. However, the reason I don't believe it is that these are clinical labs. They have different technicians. The patient tells the technician, I've been having this new treatment. It's just not blinded, not scientific enough.
Okay.
If you see something, that goes from 90% to 70% and you can't find anywhere else that is severe, then yeah, it happened. But for the most part, I think that those 90% narrowings stay like that, but they stabilize.
Okay. Yeah, that one is pretty operator dependent. So what do you foresee if we finish up the TAC2 trial? That'll be probably by 2022, right?
Yep.
Okay, so if it turns out to be positive that chelation does help us when the diabetic patients who already have heart disease, I guess the next step is how do we prevent the heart disease, and when would you start chelation? As soon as you have diabetes, or what? What is your thinking? I mean, I know it's not a study.
These are not primary prevention studies. The truth is that if it is very positive, then, people should start relatively early before they have a heart attack, but I really couldn't possibly, I've done well sort of staying within my lane, which is the patient who does have established symptomatic coronary artery disease.
Okay.
Or peripheral artery disease.
And the peripheral artery, I mean, that one,
legs.
How long was that before you opened it up? It was 20 chelations or 10? Which one was that?
That was actually, we give the first 20 twice a week.
Okay.
And then we go back to once a week for the next 20.
Okay. And that was for the 3A study, the TAC 3A study?
Yeah, that's for the legs. Mm-hmm. And then for the heart, we do once a week.
And how long was it before you saw that the people got better on the leg one?
On the leg one, the pain starts after about 5 infusions. The ones that are going to respond say, you say, well, how do you feel? I say, I don't know. My leg doesn't really hurt as much.
So
and then by 10 infusions, they say, hey, I feel better.
Mm-hmm. I was just trying to think if for our audience, if they had known peripheral vascular disease and they're diabetic, what would, I mean, in our clinic, I think that would be, if you get some benefit after 5 chelations, that'd be $1,000 to $2,000 worth of chelation. Is that right? Yeah.
Yeah. Mm-hmm. I mean, this is expensive. On the other hand, you think how much you spend for a car, mm-hmm. and how much is it worth to you to keep that leg on? Right.
That's a big piece. Yeah.
I mean, that's like serious.
But the nice part would
be,
your
toes.
For $1,000 or so, or 2,000 even, you could at least find out if it's going to work, and then you probably would be very excited to continue if you had some relief of symptoms and saw that it was really doing similar to what your pilot study had showed. So, yeah, that's cool. Yeah. All right. Well, what else do you have on the horizon?
I just need to get through with this stuff. I need to get through with this, and then if I have the energy and my wife has the patience, I may think about cognitive function. Huh. So we'll see.
Wow, that would be impressive. Because theoretically, I mean, it should do similar because we got the blood vessels going to the brain and everything.
Yeah, I mean, 30% of people with dementia have vascular dementia that don't have Alzheimer's. These are small vessel disease.
And we
I'd love to know what happens there.
There was no real piece of any of the TAC trials that looked at that, correct?
No, just anecdotes. Anecdotes from the peripheral artery patients, but enough to make me curious.
Very good. All right. Well, I really appreciate you giving your time here. I know you're a busy guy, and I guess because you still see patients and everything, right?
Yes. Mm-hmm. Yes, absolutely.
All right, and this is after 5 over there. So I want to thank Dr. Tony Lamas here coming from Miami and telling us all about the TAC 1, TAC 2, and TAC 3A trials. These were the trials to assess chelation therapy. The first one looked very positive. We're waiting on the results on the next 2. It looks like if you have diabetes and you have had a previous heart attack, based on these studies, that chelation can help you not to have a second heart attack, stroke, revascularization, or death. Was that correct?
That is precisely correct.
Okay, super. All right, Tony. Well, listen, thanks so much. I'm going to have a few more comments before our show closes, but I hope that, first of all, I really thank you for doing all of your work. It took a special person. You were the right person in the right time who knew the right people, and anything we can do to help our patients get healthier like this is so, so important. So thanks for all you do, and we'll keep our prayers going that everything turns out great.
Thank you so much.
Okay, take care.
Thank you so much for having me. Bye-bye.
Bye-bye. All right, so our listeners, we're talking to Dr. Gervasio Lamas. He goes by Dr. Tony Lamas from the Miami. This is Mount Sinai Medical Center in Miami. He was chief of medicine and chief of Columbia University Division of Cardiology there. and he was the primary investigator for the TAC trial to assess chelation therapy. So again, this show is brought to you by O3 Plus Texas, our health, wellness, and longevity clinic here in San Antonio, Texas. Our number here is 210-558-7778. So we're going to talk about some of the other things that we do here in the clinic. We have chelation, and we do exactly what Dr. Lamas has said, that is the disodium EDTA, if you are prepared to sit in the chair that long. So I'm also talking here with our nurse practitioner, Kim Engelman. She's the one who will help to assess what you need and help to run the therapies here. So I had at least one patient who did he did 30 chelations, and he went back to his cardiologist, and actually his symptoms were all good, and he showed some improvement in his neck arteries. In fact, the plaque was pretty well gone in his neck arteries, and the cardiologist was amazed that had happened. So that, granted, that's only one anecdotal patient, but we also had a patient who had severe peripheral artery disease in his legs and was getting some chelations and was able to get rid of the pain, just like Dr. Lamas had said. So, Kim, do you have any other stories of anything like that?
I've had more improvement when we've redone the heavy metal urine tests. Mm-hmm. So when we do that, we do it, as you and Dr. Lamas discussed, both the pre-provocation and a post. Therefore, we can see if it's recent exposure or if it's down in your bones, as he was talking. And we've had significant decrease in heavy metals, the iron, the cadmium, or the lead, the cadmium, and then various other ones that they are toxic with.
So as we mentioned, if you happen to look up on Google, what is the safe level of lead in your body, it will come up, there is no safe level of lead in your body. And yet, most of us have it. Again, Dr. Lamas was saying that if you lived before 1980, you probably got a lot of lead from the gas. You remember we had leaded gas. Now we have unleaded gas. But there's still lead around us all the time in batteries and different things. Also, some of the other things that can cause trouble in your body, it takes a different chelating agent to get out mercury. Mercury can come from different places like fish. So we always talk about eating healthy. We want to eat the smaller fish that don't have a lot of mercury in them. An acronym for that is SMASH fish. That's SMASH. That stands for salmon, mackerel, anchovies, sardines, and herring. Those don't have much mercury, and so those are the better fish for you to eat. What are the worst ones? The ones that stay in the bottom of the ocean all the time and eat all the other fish. A shark, for example. Tuna eats a lot of other fish, so you have to be careful with all your sushi. It's better to kind of limit how much tuna you have and try to get in salmon instead. Another one is halibut. These are fish that I really love, and grouper, but you really have to think about them and don't eat them quite as often as your salmon. Also, how else can you detoxify? Sweat is very good for getting rid of a lot of things. You can have some metals excreted through sweat. Also, you have to have your main body elimination routes open. So you need to make sure that your liver is functioning well. You don't want to poison your liver with too much alcohol. Things like milk thistle help to keep your liver functioning well. You also need to have a regular bowel movement. We don't always think about that, but that's extremely important. You need to be able to eliminate things through your stool and through your urine. Now, when we do the chelation, Kim has been taught, and as I have, how to come up with the right dose of this chemical that brings out the lead and the cadmium, the EDTA chemical. So we have to draw a little blood on you to find out how your kidney function is, because it goes out through your kidneys, and we don't want to damage your kidneys. So again, these are things that you need a medical professional to help you with. And that's why we're here at O3 Plus Texas. If you go to our website, it's www.o3plustx.com. You can find out more about us, or give us a call at 210-558-7778. So other things, I'm just, like I mentioned to Dr. Lamas, I'm super excited about linking up with the vascular clinics around here if they have diabetics that are not, they are not able to open up the blood vessels with a stent, or going in and doing an endarterectomy where they clean out the artery and they say, well, there's nothing else we can do. You're going to lose your toe or your foot. Then you might want to consider coming in and trying some of these chelations. Again, we can do them twice a week, and within 5 to 10 sessions, you should be able to recognize that there is increased flow because you won't have as much pain in your foot, and hopefully the color of your foot will look better, and then we can get some healing. The other thing we do, of course, in the ozone clinic is ozone. So it's such a great combination. If you get circulation to your feet and then we add oxygen, ozone is activated oxygen. So many people have asked me, isn't ozone toxic? The only place it's toxic is if you breathe a large concentration of it into your lung. It burns right through your surfactant, which is a protected little juice in your lung, and it can harm your lungs. So it's, in that way, it's very much like chlorine around your swimming pool. You don't want to breathe in a whole bunch of chlorine either. But in the clinic, we make the ozone when we need it from medical-grade oxygen. We know exactly the concentration that we're going to put in, and we have ozone destruct units, so you don't smell ozone here in the clinic, because as soon as we are done making what we need and we put it in a container, a syringe or a bag or whatever, then the rest of it is destroyed in a carbon, kind of like it's actually iron filings, and it turns it back into oxygen. So if anything, we have more oxygen in the clinic than a regular building. But we got ozone sensors around in the clinic so we can monitor that everything is extremely safe for you. So, again, our clinic is 03 Plus Texas, 210-558-7778 if you're having any issues. Let's see, what else should we talk about? We talked about the neck, the chelation. We went to the American Academy of Ozone Therapy meeting last weekend, which was fascinating. It was up in Dallas. We had a lot of discussions. Some was around the coronavirus. About half of it was about ozone, and the other half is about evolving therapies. So we'll be talking more about some of these things that might help for people with Alzheimer's type dementia, autism, Parkinson's. There's some really interesting stuff on plasmalogens coming out. They're available now. We're going to get to become certified providers for those, and then we can hopefully help some of you with those things as well. And again, like Dr. Lamas says, it may be exciting in the future to see if chelation might help with cognitive impairment as well. Some of the other things that they were talking about at the conference were peptides. And we've already been working with peptides. Peptides are little short chains of amino acids. A protein is a longer chain of an amino acid. The peptides act like hormones almost. They turn on and off certain parts of your body or your genome and activate certain positive effects in your body. And we have a whole list of those, and we're checking those out to see, first of all, can you get them? How expensive are they? How well do they really work? It's all in evolution right now. We are in contact with some of the leaders across the country so that we can bring all that information to you. Anything else you can think of?
No, peptides are a brave new world. We're very excited about peptides.
Mm-hmm. The other thing, there was a speaker who had been trained in St. Petersburg in Russia, and they're leading the way in longevity research. And one of the main things that hinders your longevity and shortens your telomeres, which are the protective ends on your chromosomes, is stress. So I want to emphasize everybody needs to de-stress. Fortunately, with the coronavirus looking like it's less of a problem in the U.S. right now, everybody can it looks like we're taking off masks and you can breathe more deeply and enjoy the smiles of your neighbors and give everybody a hug again. That's all super important. We were made to love one another, to take care of one another. The coronavirus got in the way, and I encourage everybody to basically stay as healthy as possible and de-stress. The other thing, of course, is exercise. So hopefully you're out there exercising, you're eating well, and we want you to get plenty of good sleep as well. So we have things that can help all of those different pillars of health. And again, give us a call here at 03+. That's 558-7778. Or the web is www.o3plustx.com. This radio show website is www.drfrankcuttingedgemedicine.com. I'll have links to Dr. Lamas, who gave us a talk on the chelation, and give you some more information about him on that website. And also we have links to our ozone clinic from that website. Well, thank you so much for being with us today. We're always here to help you. That's our goal. We will not be your physician, but we will help your physician or healthcare provider help you to get as healthy as possible. So in the meantime, keep working on your health and let us help you, and hug somebody and it'll make everybody feel better. All right. Have a great week, everybody. We'll see you next time.